Well, good evening. We're going to be talking a little bit this evening about suctioning, and we're also going to talk a little about trach care. These sort of go together. When we're doing trach care, sometimes it's important for us to suction the patient. There's mainly three routes we use to go and do suctioning. One is the nasotracheal route. This is going through your nares and down into the airway a little bit. Endotracheal, this is when we have the ET tube in place. And then tracheostomy, which is when we have the trach tube in place. The nasotracheal, we can do this on the general floor in addition to the ICU. Same thing with the endotracheal and the tracheostomy, just depending on the type of facility that you work in. Now, one of the things you want to know about suctioning, it should be a sterile procedure, and especially when you're doing nasotracheal suctioning. Normally with endotracheal or tracheotomy suctioning, that can be a clean procedure. However, you always want to make sure that you are in fact wearing gloves when you do this. So question is why do we suction our patients? And basically it's to remove secretions. When the patient has retained secretions and they're unable to cough them out effectively, perhaps they refuse to cough because of pain management, they could be weak, they could have the artificial airway in place and they're very uncomfortable with it. Anytime there's signs of retained secretions, this is when we need to start thinking about suctioning our patient. And what you can see, these are called Youngkowers. These are plastic ones. We use them with the patients. Patients like those because a lot of times if they're going to begin to suction themselves, they can use it and it works out really well for them. One thing I want you to be aware of though is if the patient does have a Youngkower, make sure you know where it is. And the reason I say that, a lot of times we'll go in and the patient will go, do you know where my sucker is? And you look and it's on the floor. Okay? One of the things you want to make sure is if you pick it up off the floor, you throw it away and go get them a new one. There's been cases where people walked in the room, picked them up off the floor, handed them to the patient, and then walked out. So please don't do that. So this is a picture of the airways, and if you look at them, you can see there's secretions in those airways. This is from a bronch. Okay, so when we're suctioning them, what we're doing is we're removing accumulated secretions, blood, foreign material, and vomitus. Some procedures that we work with, the patient will in fact vomit. We need to have the Youngkower ready for it so that we can go ahead and turn them on their sides and suction them out before they aspirate. This is kind of an interesting picture. You can see all those secretions in the airway. Another thing is if the patient has an ineffective cough, and like again, I said an artificial airway, then we may have to suction these patients. Now on your worksheet, one of the questions that you had was that you have a patient in the intensive care unit, they have a trach, and they have really a lot of dried secretions. What are you going to do about this? Well, the first thing you need to be aware of is that you have to loosen those secretions up. If those secretions are extremely dry, you try to pull those out, they're not coming. And if they do come, it's going to be kind of hard to take them out. So we need to make sure that we give them enough moisture to moisturize the secretions and be able then to take them out at that point. In the mechanically ventilated patient, why do we go ahead and suction them? One are visible secretions in the airway. We'll sometimes see these patients cough. We'll see the secretions come up. They'll be partially in the ET tube and then they'll come back down when the patient takes a breath in. Fremitus, you guys probably remember that from patient assessment. That's when you have those coarse breath sounds. If you touch the patient's chest, you can feel the rattling in it, and a lot of times that is your fremitus. Chest x-rays will show us. You remember atelectasis turns out white on the chest x-ray. We see a lot of atelectasis that tells us that patient has some retention of secretions or consolidation. We do an ABG because of the obstructed airways. Their ABG values are going to be decreased, and that's an indicator that we're going to have to do something to help this patient. And this, just to show you, this is called a closed suction catheter. It's actually attaches to a trach tube. It's very small. The ones that we use for the ET tube, designed the same way, much longer though. And so a lot of times the hospitals don't have the trach ones, and we'll use the ones for the endotracheal tubes on the trachs. We need to be aware that we're not going to put that entire suction catheter down a trach, because what we'll do is we'll run into their big toe. If they have an increased work of breathing, that could be the results of the retained secretions. We need to be able to get them out. If we suspect they aspirated, sometimes your physician will ask us to go ahead and suction these patients to see, in fact, have they aspirated. Sometimes tube feedings, they may aspirate their tube feedings, especially if the feeding tube moves and it moves up high enough that they'll start to aspirate this. A sputum sample is another one. Remember, one of the things we talked about at the beginning of therapeutics too were sputum samples. We said you can go ahead and irritate the airway with saline, hypotonic, hypertonic, or isotonic. Most of the time, hypertonic saline. So one thing we want to do when we have an order for a sputum sample is to go ahead and ask this patient, can you cough? If the patient can cough, hopefully we can get the sputum sample that way. However, if you have a patient who's obtunded, one who is unable to cough for some reason, sometimes then we have to use the suction to get the sputum sample. When we're looking for sputum samples, we can get them from the endotracheal tube, we can get them from the trach tube. If we're going to go ahead and get them from a patient who's not or does not have an artificial airway, we're going to use the NT route because that's the sterile route. And these are just pictures of suction catheters. They all come in different sizes, and they have different colors on the end. It's just a matter of what your hospital has and what they prefer. Now, some of your suction catheters are actually marked, so we know what the depth of the suction catheter is and where we've reached the airway. And that works out pretty well for us so that we don't go too deeply in the airway. So as everything else we have, there are contraindications, and we want to talk about those contraindications. One is occluded nasal passages. If you're looking to get a sterile sputum sample from a patient who doesn't have an artificial airway, we go through the nasal passages. You can't go through the mouth. There's too many bacteria and other things that are going to contaminate your sample. So at that particular point, if you know this patient has an occluded airway, sometimes even a deviated septum can cause us some problems. You need to go talk to your physician and find out exactly what they want. If the patient is already bleeding, say for example, somebody had tried to suction them, but they bounced off the turbinates and they caused some damage to the turbinates, now the patient is bleeding, we're not going to go back in and cause more bleeding. That is just inappropriate. You guys know about epiglottitis or croup. If you irritate that airway, you're going to close that airway and you're going to lose it. So we're not going to do that. Patients who have acute head, face, or neck injury. Patients who are even comatose to a certain extent will sometimes move once we start to suction on them. And when they do, now what they're going to do is they're going to go ahead and exacerbate their injury. So if we know somebody who has this, we're going to have to go and talk again to our physician and ask him how vitally important it is to do this until that injury is actually stabilized enough so that we can actually go in and suction. If they have laryngeal spasm or an irritable airway that could lead to laryngeal spasm, we need to be aware of that because you don't want to be suctioning and all of a sudden lose the airway. So hopefully, if this has been done before, we should have a note or something in the chart that would tell us, and it'll give us an opportunity to check with our physician again. Upper airway infections. Our goal is not to bring that upper airway infection down to the lower airway. So if we have a patient who has a really nasty sinus infection or something along that line, we need to go talk to that physician and ask them the same thing. How badly do you need this? Are you willing for us to go ahead and suction? And there's a good possibility that that infection is going to go down into the lower airway. And you can see over here, this is a picture of somebody with bronchiolitis. As a result of it, there's some swelling going on. Remember, with bronchiolitis, we have a lot of mucus, and we do have to go ahead, suction these patients, and we can cause some irritation. Another one that I didn't mention is basically increased ICPs. If a patient has an increased intracranial pressure, we need to be careful with those patients, because if we don't, we're going to cause some major problems with them. A normal ICP, or intracranial pressure, is between 0 and 10 millimeters of mercury. As long as it stays within that range, we're not terribly unhappy, because that's normal. Some of the procedures that we're going to do, you're going to see that a contraindication is that if the ICP is greater than 20 millimeters of mercury, we're not going to do the procedure. Part of the reason for that is if we cause more swelling to happen as a result of it, we can cause what they call brainstem herniation, which means the brainstem is going to go through the foramen magnum, and unfortunately the patient is not going to survive. So hazards and complications, you have contraindications that tell you that you cannot do it. Now we have things that can happen if we in fact are suctioning our patients. The major one is hypoxia, hypoxemia. When you're suctioning, if you remember the song by Police, "We're going to take your breath away," that's exactly what we're doing. We're taking that air away from that patient. And as a result of that, we can make them extremely hypoxic and hypoxemia. So what happens if we do this? Remember, you're going to have tachycardia, tachypnea, and a really bad outcome if you're not careful. Mechanical trauma, bleeding. We see this when we go in there, and especially when you're trying to get past the turbinates. If you're not careful and you start to push that suction catheter through the turbinates, you're going to end up with a lot of bleeding. Another problem that we have with bleeding is, say you have an ET tube, you have a trach tube. Remember with the trach tube, I told you we have the shorter closed suction catheters. Well, if you have a longer ET tube catheter on a trach and you're pushing that through and you put the whole catheter in, you're going to bounce it off the carina and you're going to cause some injuries in that area, and you're going to start to see some bleeding. As a result of all of this, we can end up with cardiac dysrhythmias or cardiac arrest. We need to be aware of that. We need to be able to monitor these patients. If we start to see tachycardia that's way too high, bradycardia that's way too low, we need to stop this procedure, give our patients some oxygen, and invite other people to come help us to make sure we can stabilize this patient. And there's your bradycardia and tachycardia too, okay? We're going to talk a little bit too about suction pressures being too high. We're going to talk about what the suction pressures are. What can happen is, if it's too high and the catheter sticks to the tissue rather, it's going to cause trauma to that tissue, and it's going to start to tear it. And we're also going to see more bleeding at that particular point. Another one we're going to see with this is sometimes these patients will start coughing. If they cough hard enough, they may end up vomiting, and then we have to watch out for aspiration. And so one of the things we always have to do is monitor these patients and see what's happening with them. We can also decrease blood pressure. We can cause a respiratory arrest. There's your uncontrolled coughing, and that's where also the aspiration can happen. And as you can see, this is a group of your fellow therapists and yourselves, and they're welcoming you to the group because today may be your first day that you actually get to suction. Gagging and vomiting are something else that we may see. Some people have a really strong gag reflex. And when we go down the nasal passages, once we get into the airways, the upper airways, we can see them starting to gag. And if they're starting to gag, get out before they start vomiting and aspirating. Laryngospasm is another one we need to watch. Bronchoconstriction, bronchospasm, pain, especially if we're pulling mucosa off. This is a patient who was suctioned. As you can see, he was very unhappy as a result of that, but at least he got better. Nosocomial infections, these can happen from us trying to bring whatever's in the upper airway down. This can also happen if we're not following our sterile procedures. If you just go in, you just wash your hands a little bit, not worry about it, pick up a suction catheter and start to go down the patient's airway, there could be something on your hands that now you've put onto the catheter, and now you're introducing into that patient. Atelectasis, especially if the pressures are way too high. There's your increased intracranial pressures, misdirection of the catheter. It's a pretty well-known fact that's a little well-known is that once you get a catheter into an area where you can no longer watch to see where the end is going, it can go anywhere it wants to. There's been pictures of catheters that went into the nasal passageway, and when they did, they instead of going down, they went up. We've also had pictures of feeding tubes that have ended up in the lungs and different places like that. So we have to always try to do the best we can. If we're starting to suction something that doesn't look familiar, there's probably a good possibility we're in the wrong place. Okay. This is a picture. You'll see this in different articles and different PowerPoints and things like that of a mucus plug that was actually pulled out of the patient. So how do we know that this patient in fact needs suctioning, and how do we know that we've done something good? Well, as I mentioned at the beginning, why do we suction? We suction because there's secretions. There's retained secretions, and the patient is unable or unwilling to remove them at that particular point in time. And now what's happening is we're affecting their ABG values, we're affecting their oxygenation, we're affecting their ability to breathe as well as they need to. And in those cases, then we need to go out and remove those secretions. If they have an ineffective cough, then they're probably not going to get those secretions up. What can cause an ineffective cough? Sedation, damage to the diaphragm, different things along that line. Some of the medications we give that aren't sedated medications, these can cause problems with your cough also. If they have phrematus, that's one of the things we know that they have retained secretions. So what's the outcome? We remove the secretions. We find that the breath sounds are better. The patient is not working so hard to have to breathe. We see an increase in their pulse ox. Their SpO2 is actually increasing. Their ABGs, if we need to do one, have gotten better also. And there's your decreased work of breathing, decreased airway resistance. It improved pressures and vital signs. Everything is looking much, much better. And as you can see, this is a person who's gone to the dentist and, they're having their teeth brushed and they're a happy person, and that's what we're looking for when we finish suctioning patients. So what are we going to monitor throughout the procedure? Vital signs. What is going on with this patient? We look at the heart rate. We're going to look at the blood pressure, the pulse oximetry, the ABG, and the skin color. If they're coughing, their face may turn red. That's an indicator that their ICP has gone up. If they're beginning to become hypoxemic, they may turn a beautiful shade of blue. So we need to look at them and make sure that they look pretty good. We want to look at the respiratory rate and the pattern. One of the things you need to remember when you're suctioning a patient, we talked about bradycardia, tachycardia, things like that. And we also talked about cardiac arrest. If you have a patient that you go in and they're breathing, say 20, 25 times a minute, you start to suction them, and now all of a sudden they're breathing 10 times a minute, you have a problem. You need to stop, and you need to apply some oxygen, and you need to get some help. With your sputum, remember we're going to look at the color, the consistency, the volume, and the odor, and we need to make sure that we chart those. Did we cause any bleeding or trauma? Did something happen? And if it did, then we need to make sure we also chart that. And the patient's response. The patient may tell you, "Thank you so much, I feel better." Don't expect that too often. However, on occasions they do. It could be that the patient just turns their back on you, but they're breathing a whole lot easier for us. Their breath sounds are much better, and their vital signs are returning to normal. And what happens to their cough effort and their ICP? We've had patients, unfortunately, who have refused to cough. As a result of that, they have a lot of retained secretions. Our physicians will tell us, "I'm giving you an order, you need to go in and suction them. If you don't, what's going to happen to them? They may end up on a ventilator. They're going to have some issues with it." And a lot of times when that happens, we'll go into the patients, and what we need to do is explain to them what we're doing. And sometimes the patients who've never been around people who've been suctioned will sit there and go, "Hey, whatever, do it. I'm not coughing." And once you start to suction them, it's amazing how their attitude changes, and they begin coughing for us at that point. It's not necessarily a reason that we do it, but it is a reason why we do it when there's problems. In the intensive care unit, a lot of times we have our monitors that we can watch the blood pressure, the heart rate, the SpO2, all of those different things. Much, much easier for us than sometimes on the floors. So the equipment, one of the things we have is a suction catheter. It's approximately 22 inches long. For the trachs, we have the smaller one. Basically, a way to determine catheter size is the size of your ET tube times 2, and then you select the next smallest size. So if you have an 8 ET tube, 8 times 2 is 16, and so we're going to go get a 14 French catheters. Catheters are measured in French. So some of the equipment we always need are oxygen device and a source. If your patient is on room air, we're going to suction them. Remember, the first thing we see as a clinical sign that we have problems is hypoxia, hypoxemia. So we're going to need to bring an oxygen device with us. We also need to make sure there's a flow meter in the room so that we can put them on oxygen. A bag and a mask. Why do we want a bag and a mask? Remember, we said that sometimes a problem is you may have cardiac arrest, you may have respiratory arrest. The other thing we can use this bag and mask with in some cases is the patient's on oxygen, but their sats are not going up. Then we can sometimes bag them, and then we can do two things. Well, number one, we'll hyperinflate them, which is really, really good, and then we'll also hyperoxygenate them. A pulse oximeter, a blood pressure cuff, because we want to monitor those. Sometimes the equipment is already on the general floor. We can talk to the patient care techs, ask them, "Can we use your equipment to go ahead and do the suctioning procedure?" Most of them will tell you, yes, that's not a problem. You also need a vacuum source. This is your suction. Remember when we talked about the zone valves, we said there were 3 things on them. One was oxygen, one was medical air, and the last one was your suction at that point. We need a regulator to connect it to in order to figure out where the pressures are, so we need to watch that. We do need those suction catheters. A suction container. One of the containers we use is called a Lucan's trap. It's a small bottle, sometimes about so big. It actually has the suction port on it, and it also has suction tubing on it, and all we have to do is connect our catheter to it. Connecting tubing, sometimes the tubing that we have, the suction tubing, is not long enough, and so we'll have to go get another piece of suction tubing and put them together. Sterile gloves, lubricant, and sometimes lavage. The lubricant we're going to use when we do the nasal tracheal suctioning because we want to bypass those turbinates as best we can. Lavage, sometimes we use that with our ET tubes and sometimes with our trach tubes. It's basically just instilling like 1 to 3 milliliters of normal saline down the airway or through the ET tube or the trach tube, and that sometimes will help us a little bit. It sort of decreases the resistance in those tubes to be able to pull the secretions out. Universal precaution equipment. You always want to protect yourself. You also want to protect these patients from you. So in this case, we're going to have to watch that pressure. This is a setup. As you can see, there's a regulator here. We'll grab our little pointer. Our little pointer, there we go. And here's your suction canister at this particular point. You can see some of the suction tubing. This is the tubing that is actually connected to the suction port, the regulator at this point. And so here's your regulator. That's going to go ahead and regulate the pressures for us. Over here is your DIS outlet. This is oxygen, remember? And then we're going to be able to go ahead and hook these patients up to oxygen then. In 2004, the AARC Clinical Practice Guideline came out with new suction pressures. With neonates, we now do between -60 to -80 millimeters of mercury. Infants, we do between -80 to -100 millimeters of mercury. Children, -100 to -120 millimeters of mercury. In adults, -100 to -150 millimeters of mercury. Now, sometimes when you're looking in the literature, people will go, well, the children's high is 120, so therefore the adults' low level should begin at 120. That is not what the guidelines say. So when you see this, the amount of pressure that you're going to use, the suction pressure, -100 to -150. And there you see negative pressure should not exceed 150 millimeters of mercury, as the higher pressures have been known to cause trauma, hypoxemia, atelectasis. Now, if you're in a bronchoscopy with a physician and you're doing suctioning either of the lavage that's been put into the patient or suctioning blood or something else, sometimes we have to increase those suction pressures well above -150 millimeters of mercury. Otherwise, we're not going to be able to pull what's in the patient's airway out. That is a rare occasion that we actually do it, that we have to, though, every time we do a bronch. But we're not normally going to go in the room and use these high suction pressures. So a little bit about suctioning your tracheostomy tube. This is a little bit with home care, but at least it shows you a little bit. There's your catheter, suction machine, the tracheostomy tube at this particular point. You're going into the tracheostomy tube, and then when you're coming out, what you do is you rotate your suction catheter as you come out. Suction is not applied until you get where you want to start suctioning. So when we're putting these catheters into the airway, including going through the nose, we do not apply suction until we hit the area where we're looking for the secretions. This is something for you to remember. Orders are a must. If you're doing any type of NT suctioning, you have to have an order. NT suctioning can end a patient's life, and it doesn't take long. You can actually kill a patient in about 30 seconds. So you have to make sure that if someone says you need to go in there and do NT suctioning, that you have an order, Do not wait for someone to go, well, I will call the physician, go ahead and start. You need to have that order before you start, okay? ET tubes, trach tubes, not that much of a problem, but we do get an order for those also. So just be aware of it, that you have to have an order to be able to do suctioning. It has to have a need. You just can't go in there and the nurse or the family member. We had a family member one time tell us, I want you to suction my spouse. And we're going, your spouse doesn't need suctioning. I've decided he does, and I expect you to do it. And we're sitting there going, I'm sorry, he does not meet the requirements of it. We are not going to suction him. And she was really upset with us. We need to make sure that the equipment is either in the room or that we gather it and bring it with us. So you can take a look in the room, see what's there, and then go pick up the rest of the equipment that you need. You always have to check your equipment. The last thing you want to do is be suctioning a patient. You go ahead and you include the suction port so that you can pull the secretions out, and nothing happens. And you're sitting there going, oh, it's not a problem. You have needed to check your equipment to make sure that it was working appropriately. Now, one of the biggest problems we have, because sometimes we forget about this, is the suction canister. When you go into the room, look at that suction canister. If that suction canister is almost full, you need to change it out. You will lose your suctioning and you will not be able to suction a patient. So always check everything you have and then look at that suction canister to make sure that it's not full. And as I said, this is a sterile procedure. So what are we going to do then? We're going to put on gloves. We need to have just regular, everyday, hospital-type gloves. We're going to go in. We're going to start setting up our equipment. We're not going to touch anything that has to be sterile. We're not going to touch the catheter. We're not going to touch the inside of the Lukens trap. We're not going to touch anything that has to be sterile. We can set our suction pressure, though. Once you set your suction pressure, you're going to go ahead and you're going to check at the end of the suction tubing, which is attached to your suction canister, occlude it and see where your pressure goes. If it's greater than a negative 150, you want to go ahead and then bring it back. You can go anywhere between a negative 100 to a negative 150. It's a matter of just what you're comfortable with, okay? So you're going to do that before you put any equipment on the end of it and before you ever start suctioning your patient. You're going to make sure the patient's pre-oxygenated with 100% oxygen and that we hyperinflate the lungs a bit. That'll help us to get those secretions out and get them to start moving. We're going to make sure that we have the appropriate gear on. This is your universal gear. You're going to have your gown, your mask, your gloves, and you're going to make sure that you wear those. When you're wearing a gown, tie the gown. You're going to see sometimes people go into these isolation rooms or they go to do a procedure where they have to be sterile and they'll throw the gown on and they may just tie them around the waist and then they leave the top untied, and when they're bending over doing something, the gown is coming down, it's opening up. The patient coughs. When they cough all the secretion all over your nice clean scrubs, and your gown is clean though. So unfortunately, the trade-off is not appropriate. And like I said, this is how you can go ahead and set your pressure. This is a pressure gauge also. If you're going through the nasal tracheal path, once you've got your sterile gloves on, you've set up your trap, or you've just set your suction catheter to your suction tubing. By the way, the suction tubing is not sterile. So you're going to decide one hand is going to be sterile, one hand is not going to be sterile, even though they both have sterile gloves, okay? So one is your clean hand, one's your dirty hand. You can use your clean hand to move your catheter, hold, whatever is still sterile. You're going to use the other one to make sure that you have the suction tubing. If you have to hold the tubing and you have to hold, say, for example, the suction canister, the Lukens trap, then that Lukens trap is no longer sterile. You can't touch that with your sterile, clean hand. But you can still touch the other hand at that point. So if you're getting ready to go into the patient's nares, you have to apply some lubricant to it. Don't put the whole gob on one time, because if you do, you're going to occlude the airway and you're never going to get anything out of that patient at that particular point. If you're going down the ET tube or the trach tube, and especially your patients who have trachs, because remember, they are not able to humidify themselves, and sometimes we do need to put some lavage there. Now, one of the things that sometimes we hear is, you guys like to lavage because you think it's going to mix with the secretions. No, the reason we're lavaging is to take away the resistance of the tubing that we're bringing these secretions up, and it works out beautifully for us. We're going to go ahead and pass the catheter until we feel resistance. A trick that I learned when I was suctioning is when I go into the nares, I stay close to the bottom of the nares and follow it around. If I hit the turbinate, I take the suction catheter and I roll it in my fingers until it rolls off of the turbinates, and then I'm going to go ahead and then pass it down the rest of the airway. Once I feel resistance, I'm going to stop, okay? And then what I'm going to do is I'm going to go ahead and withdraw that catheter about 1 centimeter. This is for adults. And then I'm going to go ahead and apply suctioning to that catheter. I'm going to count in my head 1001. That's enough time for that catheter to build up the suction pressure for him. And then I'm ready to go ahead and suction that patient. Your book is going to tell you apply intermittent suctioning while withdrawing the catheter. You do need to rotate the catheter. Sometimes you're going to see the therapist not doing intermittent suctioning because if they release the suction, they lose their suction pressure. So if they've been spending some time trying to get this to work, they're not going to end up losing those secretions, especially if they're really tenacious. For kids, we're seeing past the catheter, so it's not more than 1 centimeter below the bottom of the ET tube or the trach tube. We can sometimes figure that out. Really important for the kids and for the adults. And there's your definition of lavage. Then the duration of each pass to 15 seconds. It should not take you 15 seconds to go in there. You're going to go ahead and go in there. Once you apply suction, start counting to yourself. 1001, 1002, 1003. 15 seconds is a whole lot longer than you think it is. When you either come out of the nares or your book says one of the things is you can disconnect the suction catheter from the suction tubing and leave it in place. You'll see that being done on occasions. You do need to reoxygenate and hyperinflate those patients. Just make sure that you keep that sterile catheter sterile. Take your catheter, rinse it in normal saline or sterile water before you go back in. Monitor the patient. One of the things you want to check is, do they, in fact, now need more suctioning? If they don't, then we're not going to go back down. And we're going to try to limit the passage to no more than 3 times that we do this, okay? And it works out beautifully. A lot of times we can get the secretions out in 1 or 2 passes, okay? When you're finished, and I'm going to tell you this difference between hospitals and the long-term care facilities. In the hospital, once you're through with that suction catheter, that open suction catheter, you need to get rid of it. You need to toss it. Sometimes in your long-term care facilities, they actually keep them and reuse them again. So if that's where you're working, make sure you rinse them and keep them as clean as you can. The closed suction catheters we use on the ET tubes and on the trach tubes, they're in their own closed system, and we can use those. We normally use those for about 24 hours. We do rinse the catheter out when we're through suctioning, and then we'll change them out at about the end of the 24 hours. And this is just showing a little bit. This is showing you going down the patient's nares. Post-procedure, what are we going to do? Well, we're going to reassess this patient. How did they do? What are their vital signs? Are they in fact now recovering? If they're not recovering, then we need to get some additional help. Document everything. Document your vital signs before, during, and after. Document about the fact that the patient needed suctioning. Why did they need suctioning? And then we're going to document what happened. Was it something that was good for us? So things we're going to document: the size of this catheter, where did we go down, we went in the right nares, left nares, whatever, what was the section pressure that was set, did you make 1 pass, 2 passes, 3 passes, how many secretions did you get, the color, the consistency, the volume, and the odor. You hyperventilated pre, you hyperventilated post, you also hyperventilated between passes. And then the patient's SpO2 actually remained good, above 90%, okay? We're also going to see, how did the patient respond? If your patient is fighting you, when you document, you need to note that that patient was fairly agitated while you were doing this. Why? Because if it has to be done again, you're passing that information on to the next person who has to do this. If the patient began coughing, then we need to note that. Was it a good cough? Was it a strong cough? Did they begin to vomit? If they vomited, how did we prevent aspiration at that point? So anything and everything that happened to this patient has to be documented. If it just went beautifully, you're going to document it went beautifully. If it didn't, then we need to tell them what happened, what was done, and who did you notify. And most of the time when you're doing this, you're either going to notify the physician, definitely you want to notify the nurse, and you also want to make sure that you go ahead and document this. And so this is basically what suctioning is. When you guys go to clinicals, you may have that opportunity to do it. If it's the first time, you may want to watch and see what the therapist does. One thing I would recommend, especially if this is your first or second time, you get a little assistance. Patients who are just lovely patients, once you begin suctioning them, will turn into other than lovely patients. And they'll start grabbing and pulling things around. You always want to make sure when you're working with patients, do not put that stethoscope around your neck, because what they can do is reach up and they can grab that stethoscope and they can start strangling you with it. Make sure that your badge is on a lanyard that can break away. Otherwise, the same thing is going to happen. They're going to reach up, grab that lanyard, and when they do, if they have that opportunity to squeeze on it and to cause you to start to choke, you need to make sure it breaks away so you don't have a problem. So make sure you understand what you're doing. Make sure you get somebody to help you. It is not embarrassing. It is not, oh my gosh, people are going to think I'm the worst therapist in the world. Get the help that you need.